Hi, it's Dr. Centeno, and thanks so much for joining us today. Today's topic is going to be on when PRP should be used and when bone marrow concentrate should be used. And as usual, I'll start out with a topic. I'll sort of get the conversation going. You can ask questions at any time, and that's just by putting a question in the comments there. And then realize at the end of the day, the goal is going to be to get as many questions answered as humanly possible. And again, whether it's on this topic or another topic doesn't really matter. So getting to start on this topic, the question is whether or not you should use PRP or bone marrow. And that's bone marrow concentrate. So let's start with some definitions. Platelet-rich plasma, or PRP, is taking blood from a vein and then going ahead and concentrating the platelets in that blood and using those concentrated platelets in plasma to try to help an area heal. And we're focused today on orthobiologics, or the concept of using that stuff in the spine or peripheral joints to try to help injuries or degenerative conditions. Now, bone marrow concentrate is a little different in that the doctor takes a bone marrow aspirate from the back of a hip, the back of the hip and the back of the pelvis there, and then the stem cell containing fraction is taken out of that bone marrow aspirate after the whole thing is concentrated. And what's injected back in is bone marrow concentrate. So these are a little different. If you had to sort of give definitions simply as to what they are, PRP is like buying espresso shots for the local repair cells. Or a better way I like to say it is that if we've got a construction site and we want to make sure that all the workers get a lot done that day, we can go buy them just a slew of quad espressos at Starbucks, and then bring that to the construction site, give it to all the construction workers, and they're going to run around faster and do their things better. And so that's sort of like what PRP does. PRP contains growth factors, and those growth factors can help the local cells work harder, just like espresso shots for our construction workers. Now, bone marrow concentrate, since it contains stem cells and platelets, does that. Plus, it can also bring in something like a general contractor, i.e. the stem cells that are in bone marrow concentrate, to try to help with the whole repair response. So we'll get a little bit more done that day because we'll have more subcontractors coming in that the general contractor wants there. In addition, we'll be bringing all of our quad espresso shots as well. So those are sort of the differences between the two. Now, there are clinical conditions where one works just fine and there's no reason to do the other. So take, for example, knee arthritis. If you've got mild to moderate knee arthritis, we've got lots of good clinical data through randomized controlled trials that shows that PRP works pretty well. And there's really no reason to use bone marrow concentrate in that kind of patient. Now, if you've got moderate to severe knee arthritis, a little different. The PRP research is not as strong. And the research on using bone marrow concentrate is stronger for long-term effects. So it's that kind of conversation that I want to open up today. Which clinical condition should use which? Again, you don't have to ask a question specifically about that. You're more than welcome to ask whatever you like. But that's just to sort of get things going. So now I'm going to go and take some questions, and hopefully we'll keep that conversation rolling, have other ones, etc. Hello. I will try to be brief. Is there a DMX in Europe? Is there any help or discount program for CCI? Now I have some financial problems. Great, thanks to you. Is there a DMX in Europe? So I don't think there's a DMX in Europe. Now, there are upright MRIs with motion. And the best one we've seen is in London. I think it's Lordosis. Perhaps one of the other patients can put a link in the comments for you. But that's about as good a substitute as we've seen so far. and they do a very nice job at trying to look at the craniocervical junction. So that's the closest I can get you there. As far as discount plans, things like that, we have a randomized controlled trial that's free, but you have to qualify into the trial, and there's a chance that you could get into a placebo group for 2 treatments where we don't do anything at all. So if that's something that would interest you, then you may want to talk to Erin Dodson in our office, and she can see if you qualify for that trial. You got to qualify into it based on condition, availability, etc. Regenix, submitted advance by Harry Winston. Does it make sense to see what algo cells can do with PRP before planning coming out to Colorado for the PICL? You know, I think, Harry, it depends on what it is we're talking about. So if what we're talking about is just simple PRP into the ligaments back here, supraspinous, interspinous ligaments, and or some of the facet joints below C2, then yes, that would make a lot of sense. If what we're talking about is the high upper cervical facets and or some of the other types of ligaments that can be injected, like atlanto-occipital, or obviously anything from the front, then less sense. Stacy, hi, how you doing? Regenix, mid-advance by Sherry Shopkin. Are there any neck issues that are better treated with PRP than bone marrow concentrate? You know, Sherry, I'm really glad you brought that up, because at the end of the day, that's one of the things I wanted to get into, because that's a common question I get from patients all the time. Patients always ask me, should I do PRP in my neck or my back, or should I do bone marrow concentrate? And it depends on what it is we're doing. But let's say that we're doing a degenerative disc disease treatment in the neck or the back, then frankly, I don't see a huge advantage to using bone marrow concentrate in that clinical condition, meaning that PRP works well enough and often enough that exposing the patient to the additional risk of taking bone marrow isn't really needed. Now, listen, I would get paid twice, almost 3 times as much if I converted all those patients to bone marrow concentrate. But that's not the ethical thing to do, because a less expensive, less invasive option works really well. So the answer is, in that case, no, it usually doesn't make sense. Now, if you've got a tear in your disc, and that's a painful tear, sometimes it makes sense to go to bone marrow concentrate. If you were talking about that PICL procedure where you come from the front, then it definitely makes sense to go to bone marrow concentrate. So it depends on the clinical condition, but it's an important conversation to have with your doctor, because, you know, really for us to do our best work, we want to pick the least invasive, least expensive thing that's the most likely to work. And just picking something because it's the most expensive thing we offer and generates the highest profit margin is obviously not what we should be doing as doctors. Oh, having a problem with showing one of these. Well, using this program so far has been flawless, other than today. Seems to be locked up on my end. So I'm trying to show a question, and it looks like the question won't show. I'm going to get rid of a few connections on my side to see if we're having a bandwidth issue. Okay, sorry about that, guys. Looks like we went off there for a second. We had a little technical problem. Hopefully I'm back here. But let me get to the next question. Shanze Khan, hi, Dr. Centeno, if PRP thickens ligaments and makes them tighter, why do you still have to rely on chiropractors for curve correction? Shouldn't the stronger ligaments pull the spine back in alignment? So Shanze, first problem there is PRP wouldn't thicken ligaments, in that it would just make them stronger. So actually a strong ligament is not thick. A thick ligament is weak. I'm just trying to make sure we don't have a problem with hold on a second. I'm just communicating with my team on how this is looking. Okay, so I think we're okay there. So a strong ligament is thinner. So we'd really be talking about thinner, stronger ligaments. But Shanze, realize that there's two things causing the loss of the curve. One would be the stronger ligaments back here pulling that curve together. Now those ligaments can't be too tight because they've also got to allow you to do things like look down. The other is that if you've not been in a curve for a long time, the other ligaments are going to be tight and contracted. So that's why curve restoration and other things like that is key in trying to get rid of that decreased lordosis or curve. So we want to make sure that you're seeing a curve restoration specialist while we're working on those ligaments, if that's the main thing we're treating, the loss of the curve in the neck. Shanze Khan, have you ever injected for TMJ from both inside and, or I think inside and outside the mouth? We don't generally inject inside the mouth just because we don't see a lot of reason to in that application. Now, other applications like PICL, you need to. But for that one, we don't see a reason to do it, meaning we can see everything we need to see from out here and get to all the ligaments that we need to get to from out here. But it's certainly possible to do. I just don't see a need to do it for that. Shanze Khan, how come Dextrose Prolo works better for EDS than PRP? You know, I don't know that that's all EDS patients or hypermobile EDS patients, Shanze. I think that with the ones that I've worked on, in general, they tend to like Dextrose Prolo and bone marrow concentrate. But some also do well with PRP. So I don't know that that's all hypermobile EDS patients. I think that's pretty specific to the patient. Pia, do you think it would make sense to do PRP for a cartilage injury from patellar subluxation on the back of the patella, grade 3 out of 4, since age 14, now 48, in order to prevent more issues down the line if such injury is a risk factor for future arthritis? Well, Pia, if you have a cartilage injury that's a grade 3 out of 4, that is arthritis. So you have arthritis already. So the first thing I think you're going to want to do is to tighten down the patellar retinaculum, which is kind of the duct tape that holds that patella in the groove. And once you've done that, given what you've told me, probably bone marrow concentrate would be better than PRP, but I'd need to look at the MRI. If it is a grade 3 out of 4, then it could be on the cusp between the two. We'd probably look at things like bone marrow lesions to see if it's more bone marrow concentrate or just an intra-articular PRP injection. But certainly what you're describing, if that kneecap is still unstable, and it probably is certainly a risk factor for worse arthritis down the road. So that's the first thing. Is that kneecap still unstable? Are the ligaments that are supposed to hold it into place still there and working? And that's looking at that patellar retinaculum. Guys, here we go. Damien, good afternoon, Dr. Centeno. Do you ever combine PRP with BMC? If so, why? Also, please provide an example. Yeah, Damien, we almost always use PRP with bone marrow concentrate. And the reason is it helps to stimulate those cells. So we have lots of research that we've done in the lab that shows that adding those two together works better than just the bone marrow concentrate alone. And then for an example, it's pretty much any time we're using bone marrow concentrate. I can't think of a single clinical application where we don't use both. Does this help EDS patients? Leanne, I'm not sure what it is you're asking about because we're talking about lots of different things here. But if you mean, does injecting ligaments with orthobiologic solutions, whether that be prolotherapy or platelet-rich plasma or bone marrow concentrate, help hypermobile EDS patients? then yes, we see that that works pretty well. So that's something that that we work with EDS patients on all the time. Stacy, if C6 has moved posteriorly, can regenerative medicine get back in line with 4 or 5, or would surgery be needed? Also, for as long as C6 is not lined up, can that undermine the success of PICL? Stacy, I'd need to know more on what you mean by C6 moving posterior, whether that's posterior in movement, or this is called a retrolisthesis or a static retrolisthesis. So I'd need to know more. If it's moving posterior with extension, that's would be called a retrolisthesis and extension, and that would be treating this anterior longitudinal ligament. Probably should be treated at the same time as the PICL. If the C6 has physically moved a significant difference just statically, kind of in neutral, then it's unlikely we're going to get it back into position, and that could have an impact on PICL, but there's not a lot we can do there other than a cervical fusion, which is obviously a really big surgery. So you'd only want to do that if you absolutely knew that that C6 was causing a lot of disabling symptoms. Stevie Ann Williams, why do people with CCI-AI commonly have loss of curve? Yeah, well, that's a really good question. I think it's an important one to explore a little bit. So if you've got a normal curve in your neck and your head's up here, then those ligaments that are holding your head on are balanced, and the bowling ball is balanced on top of the curve. Now, if the curve goes away, now the bowling ball is hanging out front here. And that means you're hanging on those ligaments. So whatever's wrong with those ligaments is going to be made worse by that loss of curve. And we see that made worse as well because we see people doing this all day, right? They're looking down at their phones. And that's also increasing that forward head position, which I've logged on a lot. You know, if you could do one thing in the United States to probably save $1 trillion of future healthcare, it would be intervene early in patients who are starting to lose a curve and get kyphotic because they're doing this all day. But obviously, you know, we have an entire culture built around that now. So long story short is it works that way because those ligaments are going to have more force put on them when there's a lack of a cervical curve. And so that means we're probably going to see more symptomatic people walk in with ligament problems. And if they had a normal curve, maybe they never would have had that upper cervical ligament issue. It never would have gotten to that clinical level. Stacy, what's a curve restoration specialist? So curve restoration specialist, this is a good question. If you go to idealspine.com, I've got no association with those guys. I don't make any money off of idealspine.com. But that's the chiropractic biophysics group. And what's interesting about chiropractic biophysics is that it's one of the few chiropractic techniques that's been well researched and published in the medical literature. And what they do is they increase or try to restore the normal curve in the spine. And in this case, in the neck, that's a lordosis. And if you've got a loss of curve, they can work with you on some very specialized traction, not usually traction like this, but traction like that, forward, for example, to increase the curvature in the neck. So idealspine.com would be the spot, and it would be good to visit them if you're interested in that kind of stuff. I'm going to see if I can bring it up here and do what we did last time, the multi-screen share, because I think that's helpful for people as they're trying to follow along with what I'm discussing and what I'm talking about here. So let me try to do that, guys. Just give me a second. Okay, so that's idealspine.com. It's chiropractic biophysics, and it's a good technique to consider. We were talking about loss of cervical curve, so let's look at what that is. That would be loss of cervical lordosis is the medical way to say it. And what that means is the curve can be straight or kind of go backwards. Let's see if I can find a good picture for you there. So if you can see up in here, I'll see if I can click on that and see if there's a big picture. There we go. So a healthy neck has a normal curvature, and you can lose that curvature, or it can even go backwards. And that causes all that pressure on those upper neck ligaments. So that's what I was talking about before. So let's go on to the next question here. An opinion on low-dose baby aspirin for inflammation reduction and Pepcid AC with claritin to reduce MACS before PICL. Well, low-dose baby aspirin for inflammation is probably not going to really move the needle on healing, so that's good. Claritin would probably be fine. Pepcid AC I'd have to take a closer look at, but it's probably fine. Shanze, thanks for all the answers. Have you seen how mild EDS patients do well with PRP? Would you prefer doing mixoprolol and stem cells from the get-go? You know, Shanze, if we're talking about treating a lot of different areas in an EDS patient, we usually start with prolotherapy. If we're really focusing on a bad area for spot treatment, then I usually use bone marrow concentrate in those patients. Now, some of those patients will do well with PRP. So in those patients, we can use PRP as well instead of the bone marrow concentrate or before to see what effects we get, because obviously that's less expensive, less invasive. Pia, my son who has EDS has wrists are clicking and loose. Would you know which ligament that would need treatment, or if you're experienced or not, how can one find out? Yeah, well, the problem there is the wrist ligaments, let me bring those up for you, are complex to say the least. So as you can see here, there's just tons and tons of ligaments in there. So the way we would approach that problem is to localize it to the radial side or the ulnar side, then do what's called a 360 wrist treatment under ultrasound, where we inject pretty much all of these on both sides, the palmar side and the dorsal side, and try to get those ligaments to tighten down. And that's generally how that's treated. Now, if your son has wrists that are just clicking and they're not painful, then they may not need to be treated at all. But if it's causing him some disability, then that's when we would say treatment would be appropriate. Hello, thanks for actual theme. You commenting today. I would like to hear your opinion. Is BMAC better than SVF to use in orthobiology? Ever published plate lysate instead of PRP with them, or combined plate lysate instead of PRP with them? So when it comes to BMAC versus stromal vascular fraction, we don't really have much in the way of head-to-head trials. We've got one head-to-head trial that looks at microfat and bone marrow concentrate for knee arthritis, and they worked about the same. As far as stromal vascular fraction and bone marrow concentrate, the basic science literature would favor bone marrow concentrate right now for orthopedic use over stromal vascular fraction. But we don't have much in the way of head-to-head trials there to answer that question clinically. And then, yes, we do use platelet lysate and combine that with PRP and use that with bone marrow concentrate. Shanze, if I can ask one more, why would moving the neck cause pain in the knees, pull knees inwards, and also cause shaky legs? It's because of the impact on the pelvis. Pelvis might be unstable too. Yeah, so Shanze, the biggest concern there would be that the transversus abdominis or other lumbar stabilizers are going offline because of the neck. and that's been, or there's a reported connection there in the literature. And then there also may be separate SI joint instability in that particular patient that could be causing that, or other irritated nerves in the low back that could be causing that. For angular instability, can you inject C5-6 anteriorly despite it being close to the lungs? C5-6 wouldn't be close to the lungs, so C5-6 is going to be about right here, so not close to the lungs. And then we would be talking about angular instability and extension rather than flexion. So want to make sure that we're clear on that. So you'd have angular instability and extension at 5-6, in which case we could inject the front or the anterior longitudinal ligament. Ricardo, regards, Dr. Centeno. Hello, Ricardo. Sorry, one more, please. How do you treat facet arthrosis? Yeah, all that means is facet arthritis. So that would be treated if mild with PRP, if more severe, then with bone marrow concentrate. My C6, Stacy, my C6 shows posterior and static digital X-ray. Haven't done updated DMX. If static, not unstable, should I get fusion for PICL so I don't undermine PICL? Yeah, Stacy, I wouldn't recommend a fusion unless there's some symptoms that can be tied to C6 being posterior, meaning if we go out and we take the MRIs of 100 people in their 60s, probably 20 of them will have a posterior C5 or C6, and none of them have any symptoms. So we've got to be real careful to tie that to what's causing pain in you before we look at any kind of big solutions like fusion. Livia, Dr. Centeno, I had an AO adjustment recently, and after the adjustment of the AO, I checked my atlas by doing lateral bending, and he pushed my head too far left. Since then, I've locked up muscles on the left and poking feeling in my upper throat. Any ideas what could go wrong? Well, Livia, if you've got instability, you know, it's possible that something may be out of place. Maybe that's not the right AO person for you. So maybe find another AO person who can see if you're kind of out of place in the upper cervical spine since you kind of pushed it like that. But it would probably be an indicator of instability. Stevie Ann Williams, sorry this may have already been asked, but how can PRP or bone marrow posterior help CCI-AAI? Yeah, Stevie, so I don't think we asked that one in particular. I think we were talking more about general neck, but for posterior injections, PRP usually work well. So that would be, in this case, for CCI patients into the upper cervical facet joints, and then nuchal supraspinous, interspinous ligaments, and AO ligaments. And then doing bone marrow posteriorly, we don't do it a lot because I don't know that it's really necessary in most CCI patients. Meaning if PRP isn't working from the back, it's probably better to come from the front and do both the front and the back with bone marrow rather than just trying to do the back. Shanze, regarding looking down in flexion, could kyphosis happen due to anterior OA and AA joint instability as the neck wants to stay in flexion? Not sure what you mean there, Shanze. Kyphosis is generally a body posture like this, so I'm not sure what you're asking. Do you start with Prolo probably first, then PRP, then BMAC? Ricardo, generally we don't. We'll usually start with more platelet-based treatments. There are times that we start with just prolotherapy. So if we're talking about, let's say, an EDS patient, prolotherapy is a good bet. If we're talking about a patient with a partial rotator cuff tear, then PRP would be the way to go. So it all depends on the clinical scenario and situation. Heard a rumor you'll be out of the clinic for July and August. Is that true? Not July and August. That's kind of gotten moved to, in all likelihood, September 1st through October 15th is when I'll be out of the clinic, at least based on what I know right now. And a lot of that depends on when a boat that we've ordered is going to be ready, and with COVID and everything else, it's it's already been moved back. So I think that, but I'm pretty sure that's accurate now. Stacy, is curve restoration important and correct for PICL? If you can tolerate it. What I mean by that is a lot of our PICL patients won't be able to tolerate curve restoration. So we'd recommend they get the PICL procedure to tighten things down before they try curve restoration. So that would be the only rate limiting factor there. Shanze, following up on the angular question, yes, if the lower back tries to go into extension, the lower neck tries to go into extension, or neck flexion, so a kink. Yeah, so Shanze, if there's angular instability in extension at 5-6, then that can be treated from the front, which would be that anterior longitudinal ligament there. Stacy, static x-rays. My C5 has minimal grade retrolisthesis in respect to C6 in neutral position with no abnormal movement in flexion extension. Also have moderate DDD, same area, bilateral stenosis. Would ideal spine be able to help restore curve? Is it not fixable? I had prolotherapy injections, which has helped with the nerve pain I used to have down my left arm. I also have upper CCI as I've developed a partial punticulus on the right side that seems to continue growing. So a lot to unpack there. As far as if it's a fixed retrolisthesis, meaning one bone backwards on the other, then in my experience, usually curve restoration is not going to work. And then as far as treating DDD, that would be a separate procedure from just prolotherapy. So that would be using a platelet-based treatment of high-dose PRP in the facet joints, platelet lysate around the nerves, a pro-inflammatory type platelet lysate in the ligaments, and then possibly in muscles or tendons. So that's a different approach to try to help that kind of issue in lower cervical spine. As far as what's going on with your CCI and a ponticulus, I'm happy to take a look at that, because that kind of thing where the area that a little bone that can go around the vertebral artery growing is not something we commonly see. So I would love to take a look at that and see what's happening there. Pia, my neurosurgeon recommends ACDF, C5-6 due to central stenosis, probably due to instability. I believe this can be treated with PRP, and what would be the success rate? Yeah, Pia, there's a bunch of different articles I've written on that kind of stuff. I know that one all too well because I've got pretty severe cervical stenosis, and I have not been operated at this juncture. So we routinely treat people who have cervical stenosis. So let's see if I can get to where I need to be. Hold on a second here. Let me make this smaller. So if you go to the Regenexx blog and type in cervical stenosis, there's a whole bunch of information there, including about the sales techniques used by neurosurgeons that you're going to be paralyzed if you don't get surgery, et cetera, et cetera. Talks about my own issues with cervical stenosis, treating cervical stenosis without surgery. So there's a lot of information here, but the answer is, for the most part, most of the time, we're able to treat cervical stenosis without sending the patient to surgery by using these orthobiologic techniques. Now, that doesn't happen all the time, but it's the vast majority, probably 70 to 80% of the time. So that's something you'll have to, obviously, we'll have to take a look at. Kelly, can a bulging disc at C4, 5, 6, 7 cause headache? Generally not, Kelly. Those discs down there and the nerves that they irritate tend to cause pain or numbness into the arms or upper back, and not as much into the head. So it's really the upper cervical spine that's going to cause headache. So for Kelly, if you go to that Regenexx blog, so that's going to be at regenexx.com, and then go to the blog. And if you search under headache, and we've got a video of this, so you may need to go back. But if you look under this one, what is a proper diagnostic block headache workup? It goes through all the different things in the neck that can cause headache. And the lower levels aren't on there. It's all up in here. But it would be a good one for you to look at and read through to get a sense of what causes headache in the neck. There's a long list of things. So that's this blog, what is a proper diagnostic block block headache workup. And this is going to be recorded, so if you didn't catch that, or write down the URL, which is up in here, then you can obviously go back to the video and get it. Are there any chiros in the UK that you can recommend to correct the curve? You know, that's a good question. My recommendation is go to that idealspine.com website, and that'd be the first place I would check. If you can't find them there because of some legal reason between the UK and the US, then you may want to call that group that runs that website to see who they could recommend, because I would bet at this juncture they've trained people in Europe as well. How do you know if C6 is related to my symptoms? Yes, Stacy, so that would be looking at your clinical history, performing a clinical exam, doing diagnostic blocks at C6 or 5-6 to see if that gets rid of your symptoms. P, unfortunately, I will have to go ahead and get C0, C2 fusion. You know when it would be safe to start PRP below the fusion after surgery. Well, that's regrettable that you're getting the fusion, but it's probably going to be at least 3 to 6 months before you would want to do anything below that fusion site. And obviously, you wouldn't want to do anything below the fusion site unless you were starting to get adjacent segment disease that was symptomatic. How do I know PRP versus Regenexis is called for, considering only risks and results, not cost? I had repeated big toe sprains, culminating in one big one where one of the sesamoids tore and my medial and collateral ligaments, so maybe medial and lateral collateral ligaments, are frayed. I have limited range of motion, but it's not terrible. I already got Regenexis PRP, but had to take a strong NSAID a month after. Still, I think it helped. Money is not an issue. I want to fix it as close as perfect as possible. Yeah, so Edwin, I think listen, I'd have to look at your images to be sure, but it's certainly possible to go to a bone marrow concentrate procedure, which is Regenexis SD, and upgrade to that, if you will, if the PRP didn't get you where you need to be. But I'm happy to do a telemedicine visit and see what's going on, to see which technology makes the most sense. Now, realize that these types of injections are not easy to do. There's going to be lots of different levels of sophistication in treating something like this. So if you go to the blog, since we got that up, and let's see, which one was it? I think it's on plantar plate. I have like 3,000 blogs, so sometimes I can't find the one I need. Yeah, so this is a good one right here. It talks about plantar plate, the collateral ligaments that you're discussing here. So plantar plate down here, all the different collateral ligaments we're talking about. It also goes into using bone marrow concentrate, but this is a pretty complex injection that probably only a handful of our Regenexis sites would be able to perform at a high level, meaning that you can't just put this stuff in the joint here, which is usually what would be done. You have to use ultrasound and X-ray guidance to place the PRP into those collateral ligaments, which is not easy to do, into the plantar plate, into the tendon that surrounds the sesamoid, etc. So definitely something that, depending on who did that procedure, that we might want to take up to the next step on the procedural side, in addition to adding bone marrow concentrate, because it's not so simple. Becky, what about grade 1 spondylolisthesis that is moving and causing sciatica? PRP didn't seem to help. So Becky, I'm not quite sure, again, what you got, meaning that we're talking about lots of different levels here of procedural sophistication. So did you get the Chevy version of the PRP or the Rolls-Royce? I don't know. The Rolls-Royce would be that you are going after the under X-ray guidance and ultrasound guidance, lots of different structures there. You're going after the usual fibrous band that is where the two bones separate. You're going after the facet joints. You're going after all the different ligaments, including in that case, the iliolumbar ligament. You're going after possibly even the intervertebral disc and certainly around the nerves. And you're using 3 different platelet products: high-dose platelet-rich plasma, which is leukocyte poor, platelet lysate, and platelet poor plasma. So that's the Rolls-Royce. So I don't know where you end up in there. Did you get the Chevy, which is sort of, we stuck some PRP in the muscles back there? Did you get the Buick, which is the full-size Buick, which is we injected the PRP into some ligaments? Did you get the Tesla, which would be we injected those facet joints with some PRP and we injected the ligaments? Or did you get the Rolls-Royce that I described? They're very, very different in how they work, and all of them would be termed PRP. So I don't know if you got the Chevy Malibu or the Rolls-Royce Phantom. It's hard to say. Sally, I have a cousin with EDS having back, neck, hip pain, was treated with PRP once while little help. She's 40. What else can she do? Again, Sally, kind of the same thing I just talked about. I don't know if she got the Chevy Malibu or the Rolls-Royce Phantom there. So, that would be a good thing to go over and talk about to see what of those things she got. Because, again, the difference in procedures that we're talking about here, from the highest level providers to the lowest level providers, are like the difference between a beat up Chevy Malibu that's selling for $3,000 and a Rolls-Royce Phantom that's brand new off the showroom floor that's selling for $300,000. So hard to answer that question without knowing all that detail. Sabrina, how much more painful are cultured stem cell injections post the same day? Having at least 4 joints injected at Caymans in 2 weeks. Already had 3 rounds of PICL in lower body, so I know back pain. A cultured stem cell is going to be more painful. Not usually, no. I mean, probably sometimes less so, or similar to getting a same-day bone marrow concentrate procedure. So kind of in that ballpark. Shanze, happy to help. Steve, how does PRP help with restoring the cervical curve? Steve, as I think someone brought up before, the goal there. So let's look at that a little bit. We got a picture show and tell day. Okay, cervical supraspinous ligament. So we're talking about here, the ligaments that go back in this area, the supraspinous and interspinous ligaments. Now we can tighten these down using things like PRP injections, but you also need someone working on increasing the curve, because you've got other things up here that have gotten too tight because of the loss of the curve, and these need to be stretched. So that stretching is a critical part of doing this correctly, and that's that curve restoration that I was talking about. So it's a 1-2 punch if it's going to work well. Stacy, which diagnostic test, if it's retrolesthesis, sorry about that, is static? That would be a DMX for sure. That would be the best way to go. Sabrina, how much more painful? Oh, yeah, I got that one already. Denise, can you explain a bit more about prolotherapy? I understand PRP, BMAC therapies, but prolotherapy would be of help. Do a knee replacement that continues to be painful, even hurts down tibia at times. Would prolotherapy be good for posterior tibial neuralgia in the other leg? Probably not. Prolotherapy is where we inject a substance that causes a brief inflammatory healing response, usually in a ligament or tendon. So unlikely that prolotherapy is going to work well in a knee replacement patient that continues to be painful. The first thing in that kind of patient would be getting to a diagnosis. Is it painful because the prosthesis is loose? Is it painful because the patient is allergic to the prosthesis? Is it painful because the structure around the knee, like the tendons and ligaments, were never addressed? Is it painful because the pain was never in the knee? It was coming from your low back. So all of those things have to be looked at. We need to then get to a diagnosis of what's causing the pain, but it would be less likely that prolotherapy would be helpful than something like PRP or bone marrow treatment for that kind of clinical scenario. Corinne, I've tied most of my symptoms to increased cranial pressure due to internal jugular vein compression. Seeing Dr. Prather next week in Indianapolis to further address my atlas, the entire spine, pelvis, and muscles. I do have ligament damage, but I'm praying I can stabilize enough so my body is better prepared for the injections. Can you speak to cranial hypertension in relation to PICL or even posterior injections and the expectations of improvement for this condition for these procedures? Yeah, Corinne, I think the best thing to do for you would be going to YouTube and getting to my channel. And if you search my channel, so search my channel. So this would be Chris Centeno, MD, my channel on YouTube. And if you were to search, let's see here. I got to remember what it's under. So search Chiari. So even though this is a little different topic, it's similar. So if you go to this one, symptomatic Chiari malformation and CCI, it'll go through some very similar concepts that instability can lead, in this case, to intracranial hypertension through a Chiari 1 or 0 and how that works. And then the goal then is to get rid of the instability. Now, same thing with the internal jugular vein, the atlas banging into the internal jugular vein. The first thing to do would be to get it more stable, meaning the atlas. Now, if you can do that through physical therapy type things, then that's absolutely the way to go by far. Even if you fail that and that doesn't work, then you're going to be stronger, which is going to be part of what needs to happen to become stable, because half of stability is muscles and half is ligaments. And then if that doesn't work, then you would really consider doing something like a PICL procedure, obviously before surgery. I don't know Dr. Prather, so I'm just going to look him up just to see what it is we're talking about, because I don't know Dr. Prather. So he's an emergency medicine doctor, or is it Heidi Prather? It looks like there's a bunch of Prathers. So maybe you can jump in there. Heidi Prather's in New York. So anyway, let me know which Dr. Prather you're talking about, because I don't know a Dr. Prather. So it'd be good for me to see who that is. So guys, I'm going to start winding this up here in the next couple of minutes just because I've got a hard stop. So I'll take a couple more questions. Stevie Ann Williams, there's a chiro in Newport in the UK who does AO, and I think he can help with restoring the curve, possibly worth calling to ask. Yeah, so Stevie Ann Williams, there's normally AO chiropractic and curve restoration are two different worlds. Now, it's possible you may find a chiropractor that does both, but they're usually two very, very different worlds. So I would go to that idealspine.com site to find someone who's qualified for curve restoration. Obviously, you'd go to the AO site to find someone who's qualified to do AO, but normally they don't intersect. Rob, those who get PICL, do they also get the posterior treatments while they're Well, no. So, Rob, we just so you know, this is a good question. We do with PICL, we treat the anterior ligaments and the posterior ligaments. So those are treated at the same time during a PICL procedure. Elvis, after a couple of treatments of PRP, bone marrow, PICL, and then body start healing that area you treat, can anti-inflammatory pills stop the process of healing ligament between skull and C3, or is it okay to use? Can't find any facts about that. Yeah, so Elvis, we're talking about that pro-inflammatory part of the first month that you really don't want to stop. So you don't want to take anti-inflammatories during that time. But if at month 2 or 3 you wanted to get back on anti-inflammatories, that's fine. It's probably not going to impact that kind of healing at that point. Whereas at the outset, it will, because you've got that initial inflammatory response. And going back to my YouTube channel, we can also search ligament healing. And there's a video on that. And in this video, it talks about this, where you've got this initial inflammatory response. And that's lasting during that first couple of weeks. So you don't want to blunt that with anti-inflammatories. Now, when you get into this second response, it's going to be less of an issue. Probably still not good to take anti-inflammatories, but less of an issue than if you tried to blunt this initial inflammatory response. And then finally, you get this third response where anti-inflammatories are probably not going to have any effect, negative or positive. Stacy, would you recommend a C6 diagnostic block? Yeah, certainly. That's a good idea to see what's coming from that area. Obviously, the doctor will want to perform a physical exam to see what kind of diagnostic block is the most likely to help. Becky, good afternoon, Dr. Centeno. You've said there's a certain qualification type of physio that you recommend in patients dealing with CCI. Yeah, so Becky, I think if you're going to look for a physical therapist, you'd want to go to the Institute of Physical Art. So that's going to be IPA Physical Therapy. And that's these guys here. And they've got a nationwide network. What I like about these guys is that this is an intense fellowship program that you have to go through to call yourself one of these physical therapists. It's not just go to a weekend course. So it's a great group of therapists that operate at a very, very, very high level. Now, while they don't specifically specialize in CCI, that doesn't exist. That they know what it is. They understand how to deal with the underlying issues, and they'd be a good place to start if you're looking for a physical therapist. Tyler, I wanted to try the bone marrow stem cells. I had a shoulder dislocation, had Hill-Sachs lesion, and torn labrum, or mild torn rotator cuff. Yeah, Tyler, I mean, that sounds like a good fit. We'd have to look at your images to be 100% sure, but that's the kind of thing that would be treatable. And in that case, you're talking about an unstable ball in the socket, and we really want to try to get that stable. Stacy, can laying on one of those curved plastic devices help with C-spine curve? Yes. So that's usually called a Denerol, but I would first see a CBP specialist to get clearance to do that, rather than just going ahead and buying one of those. Edwin, levels of sophistication for injections at Regenix. I visited 2 Regenix locations, and they both had the same equipment, particularly ultrasound, live imaging, and that large articulated live X-ray viewer. Yeah, so Edwin, we're talking about, again, different levels of sophistication here based on the training at that clinic and what they do all day, every day. Now, if I knew which clinics they were, and maybe you can get that to Carol, I can certainly say, what approach they probably took. But again, we're talking about what's injected, then how it's injected. So what's injected is PRP or bone marrow. How it's injected, however, varies quite largely. Now, at Regenix clinics that are operating at a high level at a specific joint and area, there's going to be less of a difference between those clinics. But if we're talking about the average clinic that would claim to do PRP, for example, again, big difference. So I need to know more specifics there. Let's see here. I'm going to try to just take one more. I want to follow up on Corinne. This is Robert Prather. So let's see. Robert Prather. It looks like there's a lot more Prathers than I thought there were. It must be a really common name. Yeah, I'll have to spend more time looking at this guy because I don't see a lot. It looks like he's a chiropractor in Indianapolis. So thanks for that clarification. I'll take a closer look at that. Okay, guys, thanks so much for watching today. I appreciate the time that you took. I know I didn't get all the questions, so Carol will carry those questions over to our Monday session. We do have a session coming up this Monday. That session is going to be, again, live on all the channels. It would be more focused on craniocervical instability. Obviously, during any of these sessions, you can go ahead and ask any question you want about any topic, because an educated patient is a better patient. So thanks for spending the time today and watching this and asking all these great questions. I'll see you at the same bat time on Monday, 1 o'clock Mountain. So that's going to be 12 o'clock Pacific and 2 p.m. Eastern. I'm sorry, 3 p.m. Eastern. Did a bad time translation there. And we'll be broadcasting at that point on the Centeno Schultz Facebook page, the Regenix Facebook page, and YouTube. So thanks so much for watching. Have a great day. And I'll see you on Monday.